We're going to get started. Let me move this a little bit up. Can everybody hear me? You guys doing okay? Okay. Thank you all for coming. We're very excited to have you. Sorry about the food mix-up. We'll give you updates live when we know if and when it is coming. But apologize for a little bit of a delayed start on that front. So we're very excited to have Dr. Crippin here for our CPC today. So our prompt is, this is the case of a 62-year-old man with no known medical problems presenting with weight loss, abdominal bloating, and hematemesis. So we'll get into it. Before we get started, we always like to talk about the history of CPC just very briefly. So CPC started at Harvard. It was actually modeled after case presentations in the law school. It was brought over to WashU back in the 20th century by our first chair of medicine, Dr. Doc. And here's a cool picture of CPC back in the 50s. So it's a real special honor to be carrying this forward 70 years later. So first and foremost, most important part, let's meet our expert. So this is Dr. Jeffrey Crippin. So about Dr. Crippin, so he is one of our professors of medicine. He's also the Bornfield Chair in GI Research and Treatment. He's the Associate Chairman for Clinical Programs and has special clinical interests including liver transplant, liver cancer, hepatitis, and cirrhosis. He went to undergrad at University of Notre Dame, in case there are any Notre Damers in the audience. He went to medical school at University of Kansas, residency at Kansas University Medical Center in Kansas City, Kansas, and he did his GI fellowship at the Mayo Clinic in Rochester, Minnesota. 62-year-old man, no known medical problems, presenting with weight loss, abdominal bloating, and hematemesis. So first and foremost, what are we thinking?
So I chose to order this over using the things that I thought were most serious, hematemesis, obviously, then the abdominal bloating and the weight loss, because you have to think, what do I need to address first and foremost? Now you say, well, I mean, this is sort of an artificial thing for a conference. What do you mean? You just get a sentence? Think about it. You ever get called from the emergency room? Yeah, we got a guy down here, congestive heart failure. I need to come down and admit him. You don't have any idea what's going on, right? So I'm a big believer. You take that first bit of information and start to think about what are the possibilities. So with the hematemesis, it strongly suggests upper GI bleeding. Maybe he's got an ulcer. What I do, I see a lot of esophageal varices. Maybe it's a Mallory-Weiss tear. Maybe he's got an esophageal or gastric malignancy. What about the bloating? Well, I doubt that James and Francis gave me a case of constipation for the CPC, but bowel obstruction, that might then be associated with vomiting and hematemesis. And then again, what I see all the time is ascites. How about the weight loss? Big, broad topic. Not eating enough. Some chronic disease, and certainly malignancy and everything that goes with it. So when I think about what I see from day to day, I've seen this patient hundreds of times. Remember, there was no past medical history? Yeah, we see end-stage cirrhotics present like that frequently. Well, what do you mean? Nobody ever said they had abnormal liver tests? Nobody ever said they had abnormal liver tests. And so I'm thinking, does this patient have chronic liver disease? Is there evidence of portal hypertension accounting for the bleed, possibly from varices? Possibly he could have ascites, and then with the weight loss, the deterioration. One thing that when we see patients decompensate, we immediately start to wonder about, could the thing that precipitated the decompensation be a hepatocellular carcinoma? Is this what he's got? That's what we're going to find out. But those are general things I'm thinking about based on the sentence I've been given. Oh, yeah. If it's a CPC, it's got to either be amyloidosis or HLH, right? I mean, so I'm going to throw that out just to throw the hook in the water.
All right. So we're going to move into the HPI. So 62-year-old, no prior medical conditions. He hasn't seen a PCP for years. Presents to the ED, he was feeling lightheaded and then had 2 episodes of bloody vomiting at home. He also reports this 60-pound weight loss over the last year. And actually, if you dig through the notes, he thinks this is from a COVID infection he had a year ago. He denies any abdominal pain prior to the episode. He denies any change of bowel movements like diarrhea or constipation. Any thoughts based off of this?
Well, it still supports the things that I've brought up previously. You mentioned that magic 5-letter word, COVID. You say, well, that was a year ago. Yeah, we've seen some pretty nasty cases of COVID-induced, biliary tract disease. Don't think that would necessarily give them cirrhosis. You know, the 60-pound weight loss, again, it's one thing for somebody, 60 pounds, no question, that's a lot of weight loss. But did he start at 320 or did he start at 160? Because that's a distinctly different thing. If he just cut down what he's eating because he didn't feel good versus weight loss precipitated by illness. So James, I think I'm still going to stick with the things that I brought up. Again, he said after feeling lightheaded, so I got a feeling his hemoglobin is 7-ish. And oh yeah, and he just vomited again. And you know, now you're getting the call that his blood pressure may be a little low.
All right, so to give you a little bit more patient details, this is not a particularly chatty man, and I'll show you. No medical history, no surgical history, no family history, no allergies. He's not on any medications. Most probably relevant to the case, so his social history. So he is essentially not very exciting these days as far as his substance intake. He was former very mild cigarette smoker. He quit over 30 years ago. He did heavily drink back in his 20s. Again, he's in his 60s now. He's been sober from alcohol for over 30 years. He was also a heavy cocaine user around the same time, and he's sober from that as well, and he has never used IV drugs. Jumping into review of systems. So honestly, not much more new to the case. We already know about the weight loss. He does also endorse kind of generalized fatigue and poor appetite over the period of that same period of time. No fevers or chills. GI notes the occasional abdominal bloating, and then of course the vomiting as per the HPI. Beyond that, nothing all that exciting in the ROS. Now, what do we think? Anything?
Well, you haven't given me too much else to chew on, shall we say. So I'm still thinking the same thing. You know, I had an old mentor, and you all probably have heard this. You know, there's no such thing as bad historians, just bad history takers. Yeah, thanks, Dr. Smith, you know, for the vote of confidence. You know, and you can sit there for minutes, hours as you try to pull out information. Are you sure? Nope, never did that. You know, and you just, at that point, it's time to move on. You know, let's face it. I don't think you told me if this was an ER presentation.
This is an ER presentation.
Okay, so you already know that there's going to be the platter in front of you that I guess doesn't have Thai food like today, but there's going to be a platter there where you're already going to have some labs to look at. Obviously, this is structured a little different because James is going to say, what would you like to begin with? But so I don't know that I have additional thoughts. I'm going to stick by my previous differential.
Fair enough. We're going to jump into the physical exam, so it'll get a little exciting. So vitals, blood pressure, 91/43. Doesn't sound great. Heart rate, 123. A little high. Respiratory rate's normal, setting 100% on room air, afebrile, BMI is 20 to your point from earlier. I will say this was an ED documented physical exam, but they did say he's not in acute distress and he's not diaphoretic. And then the other kind of pertinent positives is that his abdominal pain or abdominal exam is mildly distended, mildly tender to palpation diffusely, does have positive bowel sounds. And then on his skin exam, they noted pallor, normal skin turgor, nothing else super exciting on examination.
Was there a digital rectal exam?
Not documented.
Oh.
I will tell you there will be melena.
Oh, there will be.
but no documented digital rectal exam.
Thank you, sir. So I look at this, and on the one hand is, he's hypotensive and tachycardic with the history of bleeding. Yeah, do you have the IVs in? Are you running fluids? Have you typed and screened for blood even before you get, or typed across for blood even before you get the hemoglobin back? The other side of that, throw the heart rate out. That's an average blood pressure for a cirrhotic. I mean, that's good. Okay. So, but again, in light of the presentation, I'm a little worried. You say pallor noted, thus that would essentially rule out jaundice. So
Correct.
he's not yellow.
Correct.
Okay. Normal skin turgor. What about the abdominal exam? I don't know. Oftentimes I hear you all and your colleagues, well, Dr. Crippin, we've ruled out spontaneous bacterial peritonitis because the abdomen is not tender. Yeah, throw that out. Whoever told you that is wrong. Okay, spontaneous bacterial peritonitis is usually not associated with abdominal tenderness. In this case, he's got tenderness, he's got bowel sounds, maybe not obstructed, but perforated viscous. These are all things you got to think about. Mildly tender is not really the sort of peritoneal sign where he hops off the table. So I don't know, James, I think I'm still going with the original differential.
All right, let's get you some labs. So
Yes,
we'll
sir.
get you basic labs to start with. So I'm not going to read these all out loud, but maybe I'll have you highlight your sort of pertinent things that are jumping off the screen for you.
So we'll start on the left with the chemistries. Again, the electrolytes are okay. Thrilled to see his kidney function still hanging in there. But then you get into the bread and butter of the liver, and you said, well, I thought you said he wasn't jaundiced. Usually people start looking jaundiced when the bilirubin hits 3 or above. Yeah, I've seen it where it's 5 or 6, and they didn't really look yellow. Keep in mind, maybe the anemia with the hemoglobin of 6.6 is kind of playing into that. The alk phos of 1358, AST of 107, ALT of 40, go to the very bottom. Whenever I see AST greater than ALT, always, and please remember this, if you haven't heard me or my colleagues say this already, got to think about, is he drinking? Well, he said he wasn't. You got to think about, is he drinking? Okay. The alk phos, kind of high. We don't have a GGT, but I suspect this is liver related. I would get a GGT to verify that. Alk phos can come from other places. So then what would give you the high alk phos? Biliary obstruction. And now I already mentioned this, the COVID infection. We have seen a COVID-induced cholangitis that looks like primary sclerosing cholangitis. We've actually transplanted a patient with that complication. On the other end, maybe this just is PSC. Maybe it's primary biliary cholangitis. Yeah, only 10% of the cases are men, but still 10%. Platelets of 383 is intriguing because that kind of points away from cirrhosis and hypersplenism. By the same token, maybe his platelet count is up as an acute phase reactant. The hemoglobin is obvious. He needs some blood. I see the MCV. That kind of makes me wonder, is this a chronic thing where maybe he's been losing blood even before he vomited blood? So I'm still, obviously, still thinking a liver problem. You want me to ask for something, or are you going to pitch me something?
Let's have you ask for something.
There we go. So I've said this when I've done this talk before. You all know that when we talk about it here, this isn't the way real life works. I'm going to ask for imaging, and James is going to give it to me immediately. You know that when you're managing a patient on blank, blank 100, you're going to order an MRI, and it may be 3 days before you get it, where we get it right away here. So I try to tailor this to what can I get quickly, thinking, frankly, that's what the emergency room is going to tend to do. So let's see, anemia, serologies. So how about, we'll do it this way. If I'm you and I see this guy and I've got a history of hematemesis, a hemoglobin of 6.6, obviously you're going to type and cross for blood, start the transfusion. But you also need to pick up that phone and call GI. Okay, now, okay, well, it's kind of late and, you know, they said they were really busy today. Call them now. And if they say, well, we're kind of busy, call me. Okay, remember that, Ed? Yeah, so anyway, so I'm calling GI, get that moving, because yeah, they may have 13 other consults they're trying to see, but you give them the history of a blood pressure of 90, heart rate of 123, they at least need to assess them. What they're going to say is, patient needs to be stabilized, give them some blood, and potentially we'll scope them later today if it's early in the day, and other times depending on the situation. We talked about, could there be some ascites? Could be. I'm going to want to know about that for sure. So back to the model of what can I get quickly? I think I'm going to order an ultrasound of the abdomen as a start.
Perfect. Let's see if this will work for me. All right. So we do have Dr. Lanier here with radiology to go through. They did get the ultrasound for you. They also got a CT abdomen and pelvis.
Perfect.
So we'll go through both of those.
With Doppler. Very nice.
Yeah, with Doppler. This is here. All right. So we'll start with the CT.
Sure. So here's the CT abdomen and pelvis without contrast, just a couple representative images here. You can see the spleen is enlarged. Its tip is coming down near the inferior margin of the right kidney. It's extending quite over into the left-hand side. There's a lot of streak artifact. This looks like this patient was imaged with his arms down, which accounts for that, those streaks going across the liver. But in general, the liver itself looks slightly hypoattenuating compared to what we would expect it to. I'm not showing you this, but there is some trace ascites. There's no biliary ductal dilatation.
So I'm looking at this and no cirrhosis.
No.
As you've mentioned, no ascites, but he's got a big liver and a big spleen.
Mm-hmm.
So then I'm starting to wonder, is there an infiltrative process? Did I mention amyloid? You know, this theoretically could be related to COVID-induced cholangiopathy. Don't think that would give you a big spleen necessarily. So I'm worried about why is the liver so big? Forgive me, was the Doppler study portal veins open?
Yeah, the Doppler study will be shown here. So here we go. So the portal venous system is patent. However, in the main portal vein, there's reversal of flow shown here. That if you go back one slide, that the right portal vein's on screen, right? That's also reversed, and then forward a slide. Here's the left portal vein, which is antegrade, but it's going out an enlarged umbilical vein.
And hepatic vein open?
The hepatic veins are patent. You know, the liver itself, the echo texture looks relatively smooth, and the echogenicity looks relatively normal, and the liver surface also looks smooth.
Perfect.
So can you walk us through what you're at, like what you're getting at when you're asking
Yeah,
about hepatic veins
yeah.
and stuff?
By the way, before I get into what I'm getting at, highly, highly recommend when you're going through your differential, take the team, go by yourself, whatever, go down to ultrasound and CT and talk to people. It's amazing what you'll learn rather than, you guys do great reports, but walking through it like you just did is really helpful. So when there's reversal of flow, that tells me there's portal hypertension. Okay, well, I thought you said he wasn't cirrhotic. Nah, you can get portal hypertension from a lot of things that aren't cirrhosis. Again, an infiltrative process in the liver could certainly do that. Important to know the hepatic veins were open. So we've more or less ruled out Budd-Chiari syndrome. But with the portal hypertension, the history of the bleed, I'm still wondering about varices, portal hypertensive bleeding. As far as why he's got the big liver, we see that for a lot of reasons. I mentioned infiltrative diseases. Besides amyloid, We see it in patients with passive hepatic congestion, particularly with right-sided heart failure. See it with granulomatous diseases of the liver, like sarcoid. And you didn't mention this, but we also see, I've seen livers that were called, big and heterogeneous, and basically the liver was full of cancer. So that's a possibility too. I'm not jumping to this, depending on what we see. Got a feeling, and I think we've got a pathologist in our midst, we're probably going to be getting a tiny piece of tissue to look at under the microscope eventually. But again, practically, you just arrived in the ER. That's not the first thing you're going to do. So this is helpful. Again, abdominal distension. I don't need to do a paracentesis because there's not enough fluid there to tap. Why is he tender? Got a big liver and a big spleen. I think that would account for it. You want to go back to the menu?
Yeah.
So, well, the ER is always, they will have already done an EKG and a chest X-ray. Could I just ask, are you going to make me read a chest X-ray?
I'm not going to make you read a chest X-ray. I also won't make you read an EKG, but since you
Thank
mentioned
you.
it, tropes are negative because it's the ED. BNP is a little bit elevated. EKG is sinus tach, normal axis, normal intervals. I will highlight normal voltages. Did have some non-specific T-wave abnormalities. We actually don't have the images. We just have the impression because this is an OSH abdomen.
Okay, so again, doesn't seem to be a major cardiac problem, but we'll keep an eye on that. With that, let me see, should I take initial labs for 300, Alex? Or no, we've already done that.
Yeah.
I'm still kind of nervous about his bleed. And so maybe could I just get an update, say over 6, 12 hours, 24 hours? Did he get blood?
Sure.
What did GI say? Because I think that's something that really needs to be evaluated sooner rather than later.
Sure. So he gets blood. He's on octreotide. He is taken for a scope. He has multiple bleeding varices that are clipped.
Okay.
And he transferred to the ICU. I don't believe he needed any pressors, and he recovers relatively smoothly. He's discharged in about 4 days. The story obviously does not end here, but that's sort of his initial presentation.
So was he discharged before there was an answer?
Correct.
Wonderful. So again, let's concentrate on his course. You've identified the main problem, bleeding and its cause. That's good. The little things that sometimes get missed, variceal bleeder, you do a scope, give them a slug of antibiotics. Afterwards, the octreotide, if they've been banded, you can get rid of that pretty quickly, but needs to go out on a beta block, a non-selective beta blocker to hopefully keep him from bleeding again. But we're right back to, we haven't explained why he's got portal hypertension other than an enlarged liver, enlarged spleen. So I'm also trying to do, James, I'm trying to think of the little gamesmanship here. I do, okay, well, but this is going to be practical as well. So work with me on this. I do think he needs to have a liver biopsy. With no offense, that is going to take a while to get, even on inpatients. And so while you're waiting to get that, I'm going to get an MRI, MRCP to get a good look at his biliary tree. Was that done?
That was not done. I will say a biopsy was done prior to discharge and is pending at the time of discharge.
Aha. Okay.
So we'll call on our friendly neighborhood pathologist shortly.
Please do.
If you want to get anything else just right before that.
Well,
you mentioned cancer, maybe an infectious.
Yeah, there's 2 ways to look at it. Again, we know in real time, yes, I'm sending off alpha-fetoprotein, probably a CA19-9 tumor markers. We can send off, he's got the history of drug use, never used IV drugs. he still gets a hepatitis C test. He gets hepatitis B. So the viral serologies, boom, there we go. He doesn't have it. And again, there's many, many, many in the room. Probably 98% of the room can tell me more about a positive COVID test now. Does that mean he's got a new case? Or is that, oh no, Dr. Crippin, in 7% of cases, that antibody can remain positive? Honestly, I don't know that. The EBV IgG, yeah, means he had mono when he was 22 years old. Not concerned about that. So we've done that. Other infectious evaluation, yeah, I'm not really hearing anything.
Yeah,
that makes me
there were some
think.
blood cultures that were unremarkable. Not that you were looking for it.
Yeah, and with the abnormal test, yes, we would have sent off things like mitochondrial antibody, anti-nuclear antibody, smooth muscle antibody. But again, then they're negative. The guy needs a biopsy. And, you know, well, yeah, but let's go through the other.
Your time has come.
Yeah. He's
All
like,
right.
just shut up, Dr. Crippin. Let's get to the meat.
All right. So yes, so he's been discharged. He actually gets readmitted with a very similar presentation, rebleeding, hematemesis, and the biopsy results. So we have Dr. Ha here, one of our liver and GI path fellows, to go through the biopsy
Good to
results.
see you face to face rather than on the Zoom call. This is how we do our weekly conference.
Yeah, so what we have here is the liver core biopsy. It really zoomed in, and the entire liver core looks just like this. So I guess I'm not sure you guys have too much experience looking at histology, but throughout the entire liver core is this really diffused acellular pink amorphous material kind of compressing through the entire liver parenchyma. I mean, some subtle hints, which I don't have in this picture, is that it's like kind of like some foreign material. Would be things like giant cells, and I think you already kind of said the punchline already. So I mean, just for confirmation's sake, we did a Congo red stain. I mean, we scanned this, so I mean, the classic thing you guys would see would be a apple green bifurengence. But even with
Doing your job.
I had to guess it.
But yeah, even without the green bifurengence, you can kind of tell just from the salmon coloring that this is definitely diffused amyloid, and this is not so subtle whatsoever.
All right. Not much of a mystery anymore.
Well, but it's intriguing. Not by any stretch an amyloid expert, but we usually think of that in association with other chronic diseases. And I don't know, perhaps he lied and we found records in an SSM chart that he'd been followed by so-and-so at SLU or something, but that didn't happen.
Correct.
So yeah, this is not a diagnosis we see frequently, but obviously we do see it. Why did he get it? I don't know. The obvious issue is it anywhere else? And again, maybe I love the line, stay in your lane, bro. So I'm going to drift across the line for a minute. You know, he probably needs a bone marrow. There's probably, what are the delta, gamma, kappa chain stuff that I forgot long ago. You're going to need to do that. And oh, did I say have Hemont come by, the local expert, to give us some insight? I have a sense that when you got a liver full of amyloid, that's probably not going to have a great outcome. Yes, there's treatment, but anyway.
Yeah,
that's
so
where
would you like to summarize our final diagnosis?
I think your final diagnosis is amyloidosis, certainly hepatic amyloid, not knowing where else it might be, resulting in portal hypertension and subsequent esophageal variceal bleeding.
Looks good to me. Well done. Well done. I almost deleted your if it's CPC, it's gotta be slide. I was like, ah, dang it, you got me. here is the actual read on the biopsy, if anyone's curious. But I think Larry did a great job summarizing. I mean, this was kind of a slam dunk amyloidosis case. And you mentioned, so we'll go through the hospital course briefly. So we sort of talked about this first hospitalization, which was kind of the majority of what we talked about. He did get some SPP prophylaxis. He was actually discharged on some antibiotics briefly, came back just 2 days later while the biopsy was still pending, had almost the same presentation, got reclipped, and then eventually actually needed a GDA embolization because he bled after the repeat scope. Biopsy resulted in the outpatient setting. All of this was actually an outside hospitalization, so this was over at Mercy. So he was following with Mercy GI for a while. He did eventually establish with WashU hepatology and with WashU hemonc. Interestingly, there was actually some debate as to whether this was multiple myeloma or just straight AL amyloid. Did get a bone marrow biopsy, like you alluded to, that oddly is very hard to find in his chart, but does seem to confirm AL amyloid. He was not a bone marrow transplant candidate. He was started on Cyborg D in December. And hepatology didn't have anything all that new to offer, but continued him on some of the therapies that were started in the hospital.
It says started Cyborg D December of 21.
Yeah, this is
So this is an
Yes.
old case.
correct.
Gotcha. Okay.
And then he was readmitted. This is actually the wrong. He was readmitted in January to Barnes. Actually, the first 2 admissions were over at Mercy, and that's kind of how he got on our radar. Unfortunately, he presented severely encephalopathic and in distributive shock. He was briefly like on quadruple pressors, and due to escalating pressors, transitioned to comfort care and did pass. I think there's a lot of interesting things about this case that I think Dr. Crippin has alluded to. Some of the things that jumped out to me were this was like very much, he didn't have very many other organ manifestations of such a systemic disease. So he had fairly normal renal function, or he had essentially totally normal renal function. We didn't go through urine studies, but he had no proteinuria. His SPEP and UPEP were like kind of on the fence, so a little bit confusing there. Hemonc did feel like some of his anemia was potentially related to the amyloid, but beyond that, he didn't have like neuropathy or some of the other classic symptoms. Like he was in this case, he was treated with a bortezomib based regimen, which was Cyborg D. He was not a transplant candidate, as I mentioned. Like Dr. Crippin alluded to, mortality rate with AL amyloid is quite high, 25% within the first 6 months following diagnosis. There are obviously different risk stratifications, and some folks do well, but many do not, unfortunately. Hepatic amyloid is common within AL amyloid, which obviously is not a particularly common illness. But up to 54% of patients with AL amyloid do tend to have hepatic involvement, which contrasts to about 18% in the AA amyloid group. And then that deposition in the sinusoidal pattern is what we think leads to that infiltrative pattern in LFTs, like Dr. Crippin got at. So any last thoughts?
Great case. Bad outcome, but bad disease. But thank you.
Yeah, thank you. Thank you for joining us. Thank you all. Yes.